we call Dr. Tanvir. She will be discussing about the diagnosis, management, and prevention of systemic complication following eye surgery under regional anesthesia. Dr. Tanvir is working as a consultant, additional professor in PGI Chandigarh, and she has keen interest in ophthalmic anesthesia. So over to Dr. Tanvir.
Yeah, good morning, everybody. So I'll be talking about diagnosing, management, and prevention of systemic complications following eye surgery. Thankfully, we're very lucky that the incidence is less, but whenever they occur, they're really a nightmare for all the anesthesiologists and the ophthalmology team. So I just introduce, I am in the Advanced Eye Center in PGI. So because the objectives are threefold, so the slide is going to go along with it. Before I come to the exact systemic complications, we need to understand that we are using different techniques. We are using the topical, various regional blocks, the details of which have already been discussed. We are using eye drops and gels, all of them. And in the eye drops, we already know what are the most commonly used, so I will just be skipping all of them. Now, in the regional nerve blocks, we have the peribulbar, retrobulbar, subtenon, and facial. So there are different techniques, and the incidence of systemic complications with all of them is very different. Till now, we just have a combined incidence of around 0.4% with all the different techniques. Before knowing any complication, it's very important to know what you are injecting. So whatever is being given into the patient is the one which is going to decide what kind of a complication it could be. It could be because of the anesthetic agent. It could be because of the hyaluronidase. It could be because of the adrenaline which is being given. Now, one very talked about topic is phenylephrine, which is used during this kind of anesthesia. And whenever we have any complication, we are always worried about that, is it really a complication? What has happened? And what kind of a complication is? So just as I briefed in my previous slides, we could have a complication because of the local anesthetics, which we call as LAST. We could just have a simple anaphylaxis. Any drug, when given in the body, can cause anaphylaxis. And the most dreaded and the most common of all the complications are the cardiovascular complications, which can range from minor complications like just hypotension, tachycardia, arrhythmia, to as severe as on-table MI or a CHF. So just as I was saying, that phenylephrine has always been talked about. So as you see the literature going back in the dates, you will find that in the previous years, it was very common that people were really thinking that phenylephrine is dangerous. But all further meta-analysis have proved that it is not a reason for concern. The 2.5% concentration leads to no clinically relevant change in any BP or heart rate. The changes which you see in the heart rate and BP with 10% are very short-lived, and generally, it's a temporary effect which is seen. But you have to be very careful in a certain subset of patients, especially diabetics who have a lot of autonomic neuropathy, and you have to be very careful in patients with pre-existing cardiac diseases. Any patient who has an increase in BP of 20 systolic and 10 diastolic, it increases the risk of stroke and MI to twofolds. So there's a certain subset of patient which needs to be identified where you might think that using higher concentrations of phenylephrine can be problematic. Then, as I already told you, that there are lots of hypersensitivity reactions which can always occur. So the hyaluronidase which you use should always be suspected, and you need to rule out infective etiologies because the clinical features always they overlap with each other. So coming to a definitive diagnosis is very difficult. So the only way, like it's a case report which I'm talking about, is that you can always do a intradermal sensitivity testing. And that is the best way which is going to actually tell you whether the patient is hypersensitive to a particular agent or not. The most important, the most dreaded is when you have the local anesthetic toxicity. We all know the mechanism of action of local anesthetic drugs, and we know about the spectrum of local anesthetic toxicities. Now, how do you identify that a patient has developed LAST? The patient can have a CNS complication, a CVS complication, which is one of the most common complications. So any patient, when complains of lightheadedness, dizziness, visual and auditory disturbances, muscle twitching, tremors, and on the worst, develops a non-stable seizure, should always be suspected of developing a local anesthetic toxicity, because the local anesthetics affect the depolarization and repolarization in the conduction pathways of the heart. So we generally have arrhythmias, hypotension, hypertension, all kind of cardiovascular abnormalities can occur. The last always occurs in phases. So the phase 1 is always the CNS excitation phase, and the phase 2 is always the cardiovascular depression phase, and then ultimately it leads to cardiovascular collapse. So who raises the alarm? It's either the monitors, which we generally use. It's always advised that even if anybody is undergoing a MAC, that is a monitored anesthesia care, and especially if we can identify that the patient is a high-risk patient, it's always important to attach monitors. And the other important is self-report. Generally, whenever patients they start reporting certain systemic, they feel anxiety. When the anxiety level rises, there's a shoot in the blood pressures. They always complain of headache, chest pain, breathlessness. So these are the things which will raise the alarm. The most important thing which we all should know is how to manage last. Now, the first ever thing when you have a complication is you call for help. We are always called, even when the patient is undergoing something under local anesthesia. And if it is really severe, then our primary concern is just to support the ventilation and stop the seizures. Seizure management always remains the same. Position the patient, give midas, see the airway reflexes. And the most important management of last lies in the lipid emulsion therapy. The lipid emulsion should always be available in all OTs or all areas where we're using the local anesthetics, because last, although incidence is rare, is effectively managed if you have a lipid emulsion, intralipid which we say. So the dosing of the intralipid is 1.5 ml per kg bolus dose, and then you can infuse at a rate of 0.25 ml per kg per minute, and you have to keep watching the patient for regression of the symptoms, and you stop giving the intralipid once when you find that there has been recovery. The important differences when you're managing a patient with last from any other cardiovascular compromise is that you should not be giving any beta blockers, calcium channel blockers, or vasopressin in this subset of patients. And you can give low dose epinephrine, like less than 1 mic per kg, a Mediuron, and even bypass can be initiated when the patient is really severe. It is very, very important for everybody to understand that propofol is not a substitute for 20% intralipid. So do not replace propofol for intralipid. And the maximum recommended dose has been recently increased. Initially, we used 10 ml per kg, but now it is recommended you can go as high as 12 ml per kg. But generally, if you have used in patients, you will find that resolution of symptoms is usually achieved with doses half of the amount. Last, patients have to be very clinically monitored, and the neurological symptoms, if they are only present without any cardiovascular compromise, they generally improve in a time duration of 2 hours. And if there is cardiovascular compromise, then you have to observe for at least 6 hours, because the local anesthetic can redistribute from the various tissue depots. Now, the important question after having any systemic complication is, from the surgeon, is that, can I proceed further now the patient is stable? So that is the dilemma which is always there. So it's not that it's absolutely contraindicated. So it can be, we can accept to proceed with the planned surgery after treatment has been given with lipid, and you can additionally wait for 30 to 40 minutes after the resolution of the symptoms to assure that last does not recur. And it is very important to take such measures only in centers which have a backup, where you can admit the patient, follow up the patient, and you have a good support of the cardiology unit and the other medical facilities. And ideally, you can actually cancel the case and postpone it on another date. It is very important that whenever you have last, it should be reported to the national registries, and it is very important to mention whether intralipid has been used or not. The most important thing is prevention, because that is what is in our hands. So we should always learn to identify at-risk patients with small muscle mass, which is very common in our Indian subcontinent, and patients at extremes of age, both the pediatric age group and the geriatric age group, are at increased risk of LAST. As I told you, patients with pre-existing heart diseases have to be always watched. The other risk factors is any patient with hepatic dysfunction, altered hepatic perfusion, low cardiac output states, even high cardiac output states cause risk. Reduced levels of plasma protein, pregnant patients, and patients who are on concomitant use of beta blockers, digoxin, calcium channel blockers, etc. Local anesthetic toxicity in children, it has to be understood, is even higher. It is a little difficult to recognize in children because they are generally under general anesthesia, which even makes the situation more difficult to be recognized. So do not think that any age group or any subset is free from LAST. Vigilance is of paramount importance. It is very important to remember that we do not have the classic representation of LAST in all cases. Half of the cases of LAST are atypical. There may not be any seizures. There could be only cardiovascular toxicity or a delayed onset of toxicity. So some other measures which you need to take whenever you're giving local anesthetics is that you have to adhere to the dosing guidelines, even if you're using a single bolus or a continuous infusion. You should use the lowest effective product concentration. You should use the smallest volume of local anesthetics, and we have just seen in the previous slide how ultrasound can be used. You should use ropivacaine instead of bupivacaine because the toxicity profile is less. You should use epinephrine to decrease the systemic absorption of local anesthetics. Aspiration, incremental aspiration is encouraged, and small doses should be injected. And you should always try and identify systemic injection via a test dose if possible. Avoid any vascular area because vascularity increases the absorption rate of the local anesthetics. Simulation-based learning sessions are to be encouraged so that if any untoward occurrence occur, we are not scattered, we are not hassled, we know the exact algorithm to be followed. Continuous surveillance is most important. There are lots of checklists which are available. I think questions we'll take up later. Thank you so much.
Thank you, Dr. Tanvir.